Hey, this is Ranee Flynn, and I'm in the chemo suite with my oncologist, Dr. Marie Beddoe, and our first guest, Dr. John Martignetti. This is the first installment of our series, SuiteTalk. In this series, we really want to be able to discuss all topics related to cancer and survivorship in a way that the average person can understand. And that's where I come in a big way, because I'm very average. And if I can understand it, then anybody else can understand it. So we're going to start off today with a great intensive topic on gene, what, Anne-Marie?
Translational gene research.
There you go. That's what we're going to talk about, and Anne-Marie is going to take it away.
We're honored today to have as our first guest, Dr. John Martignetti. John is an associate professor in genetics and genomic sciences at the Mount Sinai School of Medicine. He's also a clinical professor in pediatrics and in oncologic services. And currently, John, you run the ovarian cancer research translational program at Mount Sinai. I'm so happy that you can do this, and I want to tell you, you're really brave to be our very first guest, and I really appreciate it. I would like to start, John, if you could just tell our viewers a little bit about what you do as a translational researcher. Just give us a broad overview of what you do.
Great. Well, first of all, thank you guys. It's great to be on Fear Factor. So, thank you sincerely both for having me. Well, to kind of give you an overview, Anne-Marie, Dr. Peter Dottino and myself and people from the group here, yourself, Dr. Rudy Segna, we've established at Mount Sinai an ovarian cancer translational research group, and it's a great big title, and really what it means is that in addition to the excellent clinical care that's provided through you guys, what we're trying to do is really establish a foundation for doing research to try moving beyond what's currently known, what's appreciated, and what can be done.
So I've actually been on the receiving end of some of that. I'm an ovarian cancer patient. I like to say former, because as we go further in the series, you'll see that I like to deal with it more on a spiritual level, but I absolutely want to have that balance of science and alternative balancing of my life, where I welcome the Western science and sort of the Eastern philosophy of being well. And you've collected a lot of my samples, right?
Yeah, every week.
And so is that how you do it? When your patients come in to the chemo suite, you're collecting samples that go to Dr. Martignetti?
Yeah, but I think what John's describing is even before they get here, at the time of surgery, he gets some tissue and he banks it. And if you could just tell us a little bit about banking and walk us through that process of tissue banking.
Oh, sure. And the first and probably the most important thing is really the idea and understanding of consent between the patient and the doctor. And so we actually have a form, so in other words, if people in the future really do participate, one of the documents they'll be introduced to, in addition to hearing about, what's going to be happening to them, one of the things that's also asked of them is to participate in this research, and you have to be a willing participant, right, which means you have to understand it. So that's why this kind of a talk is fantastic. What the patient will be presented with is a document telling them what the research is for, which is...
That's the informed consent.
Exactly,
right.
Exactly. And this is a document that's prepared by Mount Sinai, that we prepare, and the ethical board of Mount Sinai has to oversee and approve. And it says specifically what we will be using these samples for. This way, if someone participates, they know exactly what can happen to their samples and why it's being collected. And primarily what they do learn also is that the goal of these studies is to help. There is, because again, this is really forward-looking, we can't necessarily say this will change, your treatment today. It certainly won't do you any harm. You've taken every precaution to make sure of that. And again, what happens with those samples if someone does consent, and again, in the 4 years that we've had this, between Peter and myself, we've had 100% compliance. So everyone that's been,
everybody has been really
fantastic.
Very interested in this.
And so what we do is, again, as I said before, is we'll collect samples at the time of surgery. And these are samples that would make no difference to a pathologic diagnosis or to treatment. These are samples that would routinely be wasted.
Right.
And we actually have someone down in the operating suite who's there, transports the material to our pathologist, who looks over everything, approves the sample, and then we rapidly freeze it or we run it straight over to the laboratory. And once it gets to the laboratory, it's kind of like a little bit of a frenetic kind of thing. Well, no, black hole, no. It's not.
Okay.
Sometimes when we look for things, but never for the samples. But, you know, the guys are quite good. So we actually have a whole production facility. The minute the samples come, and actually it starts even beforehand, where Dr. Dottino Peter will call us, let us know, tomorrow we have a case, 2 cases, 3 cases. And so samples will arrive upstairs, and immediately we have like a little triage station where some of the material is set off right away, frozen, and stored in our -80 freezers. These are big
And this
freezers.
is very time sensitive, right?
Oh, it has to be,
Yeah.
exactly. And that's why it's so important that we know in advance.
In advance, right.
We're down in the operating suites. And this actually distinguishes us from many other facilities where it's not done with that kind of forethought.
Right.
So these samples some of the samples are frozen. Some of the samples we actually take that material and we inject it into mice to try establishing cell lines. And I'll come back to that later, but it's a very expensive proposition, it's very time consuming, but we think that'll be a very important kind of thing for understanding drug resistance and maybe targeting new therapies. Some of that material will get taken off by the people in the laboratory and try to be established as cell lines in culture dishes. So right away people take these things, mince the tumor, freeze them away. More of the material then is taken away and we actually start cell cultures from blood samples that are established. This way we always have a source of DNA and protein and cell material to understand a normal cell from that individual versus the cancer one. And then all the information about that patient is actually entered into a database. So we actually have through Mount Sinai a database that's established on the web. No one can get access to it. It's actually triple coded, so you can't get access to it. But the physicians, the surgeons, the oncologists, the researchers have access to this material. So we know where it's stored, when it was collected, we know the diagnosis, we know each of the samples that we have, and whatever genetic tests are done. This is important because there's a lot of tests that are going on. I know in the past we've spoken about what are maybe really important questions. And one of those questions are many, and sometimes they change.
Sure.
What we may have thought was an important question last year.
Right, turns out to not pan out. So
Right. Or we get faced with a brand new question. So this allows us to go back and forth and not only have our researchers do work on it, but even other researchers outside of our institution who have a question.
So these questions can speak to culture or religion or where you live, geographic.
Religion, yes, sometimes in the sense that your religion is sometimes defined
by culture.
Exactly.
Right.
And so we actually take that information down because again, what we're seeing and what other groups have seen for not only gynecologic cancers but many different cancers, that your ethnicity plays a role. It may play a role in either the genes that you've inherited and so therefore may be misaligned that lead to the cancer, maybe different predispositions that you have to a cancer. So that information is taken down and kept. And again, as we do these studies, we try to think about those things as we look at the genes.
That's so unbelievable.
So the concept of the tissue bank, does every hospital have this, or is
No,
this...
indeed. It's not an easy thing to do, and it's actually one of the reasons I started working with Peter, the ability to do something like this. Not every hospital has it. Indeed, we've now signed collaborative agreements with a number of other hospitals in the area. So we actually have an agreement with the hospital in Long Island, soon to have one in Brooklyn.
Where you will store this tissue? Okay.
So the tissue will actually work with them and they'll either be sent and transported to Mount Sinai, or it'll be kept with them.
I see.
But what it does is...
You have access to it. Everyone has access.
Exactly. Again, our idea is that if we're going to make a difference in this disease, researchers need to get access to this tissue, and it shouldn't be just held by us. This should be something open for serious researchers who want to look at something, want to try understanding something. They should have the availability of this tissue.
And this should be international at some point.
Well, that's it. Your collaborations have now extended overseas to other countries.
Exactly. So, originally when we started some of these projects, we were working with groups in Canada, in Italy. We've actually just now started working with something called the TCGA, the Cancer Genome Atlas, which is an international collaboration of scientists all over the world looking at genetics of particular cancers. So we're actually now a participant in that. And again, for us, it gives us access to other scientific minds. And I think for the patient, what it does is it takes a relatively rarer disease, ovarian cancer, as opposed to breast or colon or colorectal. And that rarity has made it really difficult for people to do research because you can't get the numbers of samples you need.
Right.
But by collecting these and then forming these large groups,
then you can share information.
You share information, you share samples, and you can really get something done.
I'm not sure how far along you are with your studies on genes, but if you're born into a set of genes, can you sort of outrun them or change them or alter them? In other words, if you seem to be predestined or disposed to something, does that mean that it's going to happen, or can you sort of jump in and say, whoa, Nellie?
Yeah, I think kind of it's like the fault lies not within our stars, but within our genes, in a sense.
I don't like that answer.
I know. But, it's the genes that also give you certain strengths, right?
Keep it coming.
Exactly. And I think, again, probably what we're seeing now, and, when I first started, even as a medical student, this was the kind of the hope you would have one day, to try thinking about your genetic strengths and try understanding and tailoring medicines and treatments and, even proactive schemes based on your genetics. And I think we're actually getting to that point now. And indeed, for a lot of medications, you will do that kind of a genetic test and specifically tailor what you receive. And the treating doc will have an idea of how likely you are to respond to a drug or not, and so can tailor your therapy. So even though we necessarily can't change our genes, we can actually be proactive in understanding them and then applying that knowledge and being smarter.
But there's also such a thing that the environment can affect your genes and cause some mutations and things that you may not have inherently been, genetically just predisposed to. That environment can play a role and make you more susceptible to something that you weren't born to be susceptible to. Is that?
It is, and I think the frustrating bit, and I think you know this too, is the things that we definitely know will alter your thing. Smoking, overeating, so many, and yet.
Did you say overeating?
Overeating. Oh, sorry, overeating.
Don't scare him. Don't scare him. Or either. And yet still people don't change those habits, and yet they're clearly linked to
ultraviolet rays. We still sunbathe a lot. That definitely.
But there
some
are
changes.
there the genes that come from your family, and your family is from this region. Does that explain why there are some people where, remember when they would always say nobody gets breast cancer in Japan, remember?
Right.
And then now it became westernized and there's McDonald's and now there's a lot of, so I'm wondering, aren't there people that are predisposed to this gene pool and they never get cancer? Like where does that?
Sure. Right.
Like how?
We
What
see
does that mean?
BRCA-positive patients who
Right.
never develop.
So something external has to be affecting the internal, right?
There are, without a doubt, and I think.
See, I like that. That gives hope that you can actually be proactive. Like you're born into some set of whatever, and if you just stop doing this and do more of that, maybe your genes don't determine the end result all the time.
Right, and with anything, you're exactly right. The genes will not predetermine everything. They will kind of push you in certain directions. And again, the knowledge that you may be at risk for something, again, you can adopt preventative strategies.
Yeah.
Again, I would say that they may not always work because we don't still know how strong some of those genetic pushes are. And so what I would say to someone,
it's a ticket, isn't it?
But someone on the other hand shouldn't feel guilty. Oh my goodness, I did everything I could. I did this, I did that,
Right.
I didn't do this, I
Right.
didn't do that, I should have done this. I don't think they can be necessarily held at
Right.
fault if indeed something